Excellent. Guys, thanks for coming. I appreciate it. My group is coming up from Arizona, so it's 110 degrees today in Phoenix. So I would have come and talked about anything today to get out of Phoenix and be in Seattle. I'm going to talk about the physician, the clinical, the healthcare provider side of our acceptance towards CBD, what our goals are with CBD, some of the obstacles with acceptance in the medical community. I'll give you a little bit of a background of myself in terms of how I became involved in the CBD realm. A lot of it goes back to my interest in neurodegenerative disorders. I did medical school in University of Colorado and a residency at Stanford University for anesthesiology. And during that, I published some papers on neurodegenerative disorders, astrocyte and glial proliferation, and alcohol toxicity. And so I vacillated between neurology and anesthesiology quite a bit. Ended up proceeding with an anesthesiology residency, loved it, but also became very involved with chronic pain and how we treat chronic pain, some of the neurodegenerative disorders that go along with chronic pain, MS, Parkinson's, Huntington's, and a variety of other disease processes. After residency, I went to Harvard for my fellowship in interventional pain, and that was a conglomeration of interventional training as well as medical management of complex pain-related issues. Since then, I've been in Arizona since 2007 doing exclusively chronic pain. My colleague Peter Kubitz, raise your hand in the audience. We have a group that is specifically catered to chronic pain issues. We have 3 locations, 7 providers. We treat about 40,000 patients per year. As a board-certified anesthesiologist and pain specialist, have a chronic pain mindset clinic, also board-certified, and we generally deal with complex chronic pain issues on a daily basis. And a lot of these are spine, and we'll get into sort of the subsets of that. But in the last 5 years, Arizona and many, many other states have had a retraction in terms of how we treat our patients. I'll take you back to 2004 when I finished my fellowship at Harvard. From a chronic pain community perspective, there was a very still pro-opioid stance. It was the decade of pain, if you remember. Hospitals were being reimbursed on aggressively treating pain, and opioids and treating patients with opioids for better function was prominent. From a big pharma perspective, OxyContin was branded and big. There was a transitioning, certainly at the Northeast where I was, from OxyContin to the fentanyl patch, or the Duragesic patch, if you remember. So it was switching from one potent opioid to one extremely potent opioid. But that was really 15 years ago, the sort of mantra with specific severe pain issues. We had no issue with treating patients with opioids. And a lot of people are pointing the finger at each other these days in terms of the opioid crisis. And I'll be the first to say that as a physician who was trained in the early 2000s, we were told that to be aggressive about opioid therapy and treat with function. We knew about addiction, we knew about dependency, we knew about some of the other side effects, but we didn't know 15 years later that we'd see some significant ripple effects. So about 3 or 4 years ago, in Arizona certainly, but in other states, we had a lot of issues with the retraction of opioids, whether it was the government, the state, third-party providers, insurance companies. I was on the governor's committee for the Opioid Epidemic Act in 2018, and it was eyebrow-raising to me. Probably about 30 to 40 people on the committee, Department of Health Service, various clinicians, people from the VA, people from the addiction community. But it was a very, very, it ended up being a very, very heavy-handed attitude towards anti-opioid regulation. Personally, my stance is that Healthcare providers should have that armamentarium of whatever they want to treat and treat that judiciously and safely for all of our patients. Usually when government gets into medicine, it comes with a very heavy hand, and a lot of unintended casualties come about, and that's certainly the case with opioids generally from my perspective. In any event, the silver lining is that because of the pretty prominent opioid retraction, Peter and I became aware or more aware or looked to a lot of our patients who were looking elsewhere. A lot of people were being reduced on their pain medications because of United, Aetna, Cigna have said we have to get you down below this level. And we had patients who were anecdotally telling us about CBD. And this was probably 2015, 2016. And we had always practiced with a comprehensive mindset from a natural pain medication perspective, coenzyme Q10, alpha-lipoic acid for nerve pain, turmeric, various other medications we incorporate into a medication regimen for our patients. But CBD was new, and CBD was very interesting to us because anecdotally of efficacy and seemingly a low side effect profile. To get traction into the medical community, though, we knew that we had to get data. And so Peter and I decided to step in a couple years ago with both feet and start the Physician's Choice CBD company, where we looked at CBD, which was sourced with vitamins and minerals and other nutraceutical supplementation for specific pain issues that we saw in our clinic every single day. Nerve pain, inflammatory pain, spine pain, migraine, complex headache. So that's generally how our group got started. This is a sort of a little swath of a subset of what we see on a daily basis. Probably about 60 to 70% of our clinic is spine-related pain. You playing tennis and you throw out a disc and you get a sciatic down the leg, lumbar radiculopathy. Lumbar spondylosis more speaks to arthritis of the spine, degeneration of the joints in the spine. Scoliosis, whether it's acquired, congenital, or occurs later on in life, is a common issue for patients with low back pain. And then the litany, the plethora of patients who have had low back surgery and either had minimal benefit or great benefit, and the pain had come back, is a large portion of the spine pain that we see. From a rheumatologic perspective, the opioid epidemic also caused a minimization of the healthcare providers that provide pain medications, and primarily opioids for pain. There's currently no large rheumatology group in the state of Arizona that's prescribing opioids. So a lot of those patients hemorrhage to pain specialists who, under the law, were a little bit more protected in terms of their prescribing. But we see a lot of rheumatologic pain because of that: lupus, Lyme, Sjogren's, rheumatoid arthritis. Very, very severe, very chronic. You manage the symptoms. Some of the new biologic medicines are excellent, but generally this is symptom management for someone that is debilitated from large or small joint issues. Degenerative osteoarthritic pain, that goes without saying: knee, hip, shoulder, all the various issues in terms of pre-surgical, post-surgical, patients who are not surgical candidates who have significant joint-related issues. So nerve pain, large portion of the practice as well too. This is one of the more difficult subsets to treat. From a spine pain perspective, we have a lot of interventional therapies that can be beneficial. From a rheumatologic pain perspective, I think a lot of the newer medications are excellent. Nerve pain continues to be difficult. Trigeminal neuralgia, postherpetic neuralgia, phantom limb syndrome, reflex sympathetic dystrophy. These are a few examples of some very, very severe nerve pain syndromes. We treat those classically with nerve pain syndromes. Unfortunately, a lot of them cause some side effects, and we'll get into the nuts and bolts of that. But these are difficult nerve pain issues to treat. Diabetic peripheral neuropathy is another large one, not in the group there. Specific neuropathies, getting to that, these are distal neuropathies typically that are separate from a disease entity or a secondary, come from a secondary cause. Diabetic neuropathy, as I mentioned, post-chemotherapy neuropathy, multiple sclerosis neuropathies, end-stage liver and kidney disease. Each of these disease processes usually has a neurologic core, but either the treatment in terms of post-chemotherapy neuropathy or the secondary sequela of the disease processes can cause significant nerve pain, burning, tingling, severe pain and numbness, typically in the lower extremities and then progressing to the upper extremities. Lastly, complex headache. This is also a very difficult subset: tension headache, migrainous headache, frontalis headache, occipital type headaches. These are all very difficult aspects. We usually treat concomitantly with a neurologist. There are a few interventional therapies that can benefit, but it's a large patient of symptom management sometimes for these groups too. And from this, you're generally looking at a patient population that is primarily working, primarily has families and spouses to treat. So we balance a lot of the medications with a keen eye on their cognitive issues. With the exception of the non-steroidal anti-inflammatories, and again, I'll get into the specifics, with the exception of the non-steroidal anti-inflammatories, every single prescribed medication for pain has effects on the CNS. Opioids, neuropathic medications, skeletal muscle relaxers, some of the other more esoteric medications, tricyclic medications, they all can make you sedated. Cognitive issues, word finding difficulty, slurred speech, short-term memory loss. These are all issues that we try and balance, occupational benefit as well. Okay, so briefly, more than 35 states in the last 2 years have changed their opioid prescribing laws. I can speak to Arizona, and I've been on a couple national committees, and I can speak to the national landscape. But generally speaking, a lot of it has come down to the oral morphine equivalent. Generally speaking, this is the number that you're assigned if you are on a pain medication. If you are taking morphine 30 milligrams twice a day, your oral morphine equivalent is 60. If you're taking oxycodone, it gets a 1.5 multiplier because it's a little bit more prominent. So that is 40 milligrams would become 60 milligrams. So 60 oral morphine equivalent. So this is, if you talk to a patient who is a chronic pain patient, a very important issue that they are unfortunately dealing with, because these are what causes the limitations now in terms of you cannot be above X. And that's how they determine X is the oral morphine equivalent. This is a little bit more national issue. Again, I spoke to the difference 15 years to now, 2004 to 19. How I was trained in 2004 is markedly different how pain specialists views medications generally now. And whether it's national, the CMS, state-wise, this has affected legitimate patients who have chronic pain issues, and this has also affected the illicit drug trade. Clearly, illicit fentanyl is the classic example right now. I'll just speak to this one too, and it's created two different pain crises. I really should say opioid crises. One is the plight of the chronic pain patient who has had their medications reduced significantly, and the other one is the inability of our government or money putting into mental health services to deal with this huge trajectory of illicit opioid use, specifically fentanyl and heroin, look to be on the largest trajectory for people with addiction issues. So here are options for a patient who wants to or wean down on opioids, whether it's the narrative they do not want to be on, they have some intolerable side effects, nausea, vomiting, constipation, or they may have some dependency issues that they're struggling with, or addiction issues. So all the non-opioid medications, non-steroidal anti-inflammatory agents, neuropathic medications, skeletal muscle relaxers, partial opioids, tramadol, tapentadol, buprenorphine is currently being used actively in this category. You can increase or add adjunctive therapy, other therapy modalities, chiropractic modalities, acupuncture, massage, ketamine IV, a variety of different avenues that are coming out there. And then there's the medications to address specifically the withdrawal symptoms. So the concerns regarding the current options, I'll delve into these short term, but acute and chronic renal failure, GI irritability from mild irritation to outright bleeding ulcers are an issue with anti-inflammatories. Neuropathic and skeletal muscle relaxers, as I said, cognitive being the main issue. Partial opioids and opioids dependency, some of the typical side effects, nausea, vomiting, constipation, and addiction being the large one. And other non-narcotic concerns. I generally feel that in this category, we're talking about benzodiazepines, the proliferation of benzodiazepines, which I believe is going to be the next narrative, Klonopin, Xanax, Ativan, Valium, to mention a few. So in a circuitous route, I just want to quickly hit on why we feel CBD has a prominent place for patients who are in pain, who need help with coming down potentially on opioids or supplanting some of the other medications that are causing intolerable side effects or side effects that are causing medical comorbidities. So this was a British Medical Journal article, and the actual article title was about gabapentinoids, suicidal behavior, increased motor vehicle accidents, and violent behavior. This actually came out last month in the BMJ. And basically, it looks at gabapentin, which is the most prescribed neuropathic and anti-epileptic medication, and Lyrica, which is its sort of secondary cousin there. But basically, they said that there was an increased incidence, Lyrica more so than gabapentin, on each of those issues: suicidal ideation, suicidal behavior, violent crime, and road traffic incidents. So it highlighted the fact that one of the more benign medications that we use for neuropathic pain is causing some serious issues. So that was over in a study in London. This is a little bit more over in the States here, and this is ground zero for opioid addiction. This is Ohio, and this is where the Board of Pharmacy has looked at gabapentin and the illicit use of gabapentin, the street value of gabapentin, where it's being used for mitigating some of the highs, or at high levels of gabapentin, creating a dull high in itself too. So it was the #1 medication written in that area. These are some of the breakdowns from the states where gabapentin abuse was started to be noticed by each of the county health services for illicit use in the street. So you can see proliferation there coming up to January 16, and that's, I suspect the data is going to be significantly increasing. From an anti-inflammatory perspective, these are medications, these are the medications that we prescribe that don't have cognitive effects. Many people lean on these very heavily. Over the counter, you have ibuprofen and naproxen, and then we have some of the more prominent ones, diclofenac, etodolac, piroxicam, meloxicam from a prescribed perspective. Really, it's GI issues, it's renal issues, and it's cardiovascular issues. Anyone remember when Vioxx came out about 10 years ago? So Vioxx was the prototypical medicine that highlighted this. It got taken off the market because of cardiovascular and stroke risk. And since then, there's been FDA black box warning on diclofenac, but much more highlighted that these medicines are very good anti-inflammatory medications, but can cause a host of issues. And that middle one is not hermatology, the study of females, that's hematology. Just FYI, there's a typo there. So this is some opioid concern, and just to say that relative risk of renal failure certainly does go along with the over-the-counter medicines. Just because it's an over-the-counter medication, you can see naproxen and ibuprofen in there, does not mean that it's without risk. So high doses, long-term, that is a significant caution for this subset of medication. 100,000 patients hospitalized. 16,500 people die from NSAID-related complications. Again, just underscoring its not very benign nature in a general sense. Lastly, just one slide on skeletal muscle relaxants. Soma being the prototypical one that's been under highlight. Its metabolite is a medication called meprobamate, and somacoma was the term back in the 70s and 80s. It's a barbiturate-like metabolite. And so Soma mixed with alcohol has had a significant amount of opioid hospitalizations and deaths associated to it. So most physicians are not prescribing this, but you do see this a decent amount still. Flexeril, you can see, or cyclobenzaprine, the commercial name, also implicated there with about 1% of cases, including non-medical use of pharmaceuticals for hospitalization issues. Okay, so a long-winded way of saying, I personally feel, just as a pain physician, from what I've seen, teens, people in their 20s and 30s, the baby boomer population in Arizona, that we seem to have somewhat of a breakdown in terms of our abuse of prescription medications. We have a tremendous addictive issue as it relates to opioids that we know of, but in a general sense, prescription medication abuse, opioid and non-opioid, as our alternatives for primary and alternative medications for pain, are not great medications. And that's sort of the underscoring bottom line that we see here. 16 million people abusing prescription medications, men more so than female, predominant upswing in teens currently, and after marijuana and alcohol, the most common drugs teens are using and misusing are prescription medications. Okay, so all this came together 2 or 3 years ago for Peter and I, that we felt that CBD could be beneficial for a chronic pain population. We saw no data. We figured we had to jump in and provide that. Can CBD, with other natural medications, help in the chronic pain population? Can CBD with the other natural medications help with reduction of opioids? So can it help with pain? Can it help with the reduction of opioids? And can it help with some of the intolerable other medications that we have where the side effect profile is intolerable? So these were the subsets of the patients that we were looking at. Patients who had prosthetic heart valve, they're on blood thinners, they can't take anti-inflammatories. Patients who had multiple ulcers, they can't take anti-inflammatories. Patients who had cognitive effects with gabapentin, with Lyrica, with amitriptyline, with Cymbalta, other types of issues with the neuropathic medications. Refractory cognitive effects with complex headache, muscle relaxers, and other non-opioid medications, benzodiazepines being the key one there. And then the highlighted one for us is, can we help with this opioid-related issue and provide our patients with an alternative, an excellent natural medication that seemingly had a lot of benefit where the data is increasing there too. So currently, our group is undertaking a number of studies. We're looking at CBD with opioid reduction. We're looking at CBD and reduction of prescription medications. We're looking at CBD pain relief on just pure VAS scores, sleep benefit, anxiety benefit, and acute pain studies, post-surgical studies as well too. So this is just the general data set. I'll speak to this for a bit. It is a 10-month data set. It'll be a year when I calculate the end of July. These are patients in our clinic who have expressed interest, whether it's voluntarily from the patient or with consultation with the physician, in terms of reducing their opioids. This may be a patient who's been on opioids for 10 years and said, listen, I don't want to be on opioids the rest of my life. Can you help me out with something else? Or this may be someone who is working in a job and has had an issue with opioids in their job. Police officer, long-haul truck driver, pilot, someone who can't take opioids or has been taking opioids and cannot anymore take opioids because of the increased stringency. In any of these scenarios and multiple others, for the last 10 months, starting July actually of last year, we've undertaken a study, a prospective study, in terms of providing that patient with CBD in an effort to help them come down on their opioids, ostensibly providing them with pain relief as well as providing them with lack of anxiety and the stress that typically goes along with reducing their medications. We excluded quite a few patients. Online, those patients were excluded. Yes, sir?
Quick question. What type of CBD are you providing to patients?
You bet. I'll get to that in 1 second. Absolutely. Yeah, absolutely. Sorry, I'm being long-winded. So generally speaking, so the patients for online that we couldn't track were out. These were patients that saw us in clinic on a monthly basis because of their opioids. So we had the ability to track them specifically. We also, in terms of another study, we always do urine toxicology, LCMS or GCMS testing. So we're undertaking a study now verifying that with our CBD, there's no THC content. And that's obviously for people that are very strict, long-haul truck drivers, pilots, police officers, and that group. These are patients who maintained their typical pain regimen, meaning if they had osteoarthritis of the knee and they got a definitive total knee arthroplasty, they were taken out because they had definitive therapy. So we tried to make sure that no other pain therapies deviated from their norm. So you can see there was a subgroup that did not benefit. There was a subgroup that benefited partially. I highlight the 33% or greater just because is sort of a speaker for some big pharma. The greater than 33% is seen as the threshold for verifiable pain relief for patients typically. So generally greater than 62% of the patients had greater than 33% benefit of opioid reduction. And you can say a good 32% had greater than 66% too. This number is continually changing too. We have multiple patients that are still in this trajectory that are coming down. And every month or two, we have another patient that hits the mark on a more prominent opioid reduction here. So to your question, we wanted to keep the CBD, obviously for a study like this, the same. So we kept it with our specific CBD, which is grown in Colorado. It's extracted in Washington State. We added some nutraceutical supplementation that's specific to each of these. For example, the pain inflammation, turmeric and ginger and piperine, the migraine, coenzyme Q10 and riboflavin. So each of these has specific nutraceutical additives to this. But the CBD is the same, and we wanted to keep the CBD the same. There's a lot of other very good CBD companies out there, but for our study, obviously we wanted to keep it the same. Obviously with the limitations, we're in an age, we're in a narrative, the media, the government, that's the embracing opioid reduction. So there was a lot of that, their spouses, their family, that were all pushing for this. So we realize that and we understand that. There was a wide distribution of the opioid reduction, meaning there could be someone on 3 Percocets a day, and if they come off, that is 100%. But there could also be a patient on OxyContin 83 times a day and Roxicodone 34 times a day, and that patient has come down from 400 milligrams or so, and that's off, and that's a huge win. So both of those were counted under a 100% reduction, and we're parsing that data as well too. So some was a small reduction, some was a relatively large reduction. And then the dose was wide. We typically have our capsules, and we typically tell our patients 1 capsule twice a day. There are some patients with a little bit more robust that are taking 2 capsules twice a day, but generally it's 1 capsule twice a day. There are some patients who are taking 1 capsule once a day. So the range of the dose for our product ranged from 2.5 per day milligrams to, 12.5 milligrams per day to 100 milligrams per day. And then reduction of a couple other highlights here, reduction of non-opioid pain medications. These are some of the other medications that patients who had intolerable side effects from a non-opioid perspective were able to use the CBD, benefit from that, and come off. Gabapentin as a neuropathic agent, Cymbalta as a neuropathic agent, plethora of anti-inflammatory medications for people that had issues with bleeding, GI distress, skeletal muscle relaxers, cognitive, headache medications, amitriptyline as a tricyclic medication, and then the opioids as I discussed. This was also very important to us. Could we provide this natural medication, and was it going to have any drug-drug interactions, and was it going to be palatable from a side effect perspective? We were pleased to say that over the course of almost a year, and again, this is ongoing, we have less than 1% side effects for each of these subsets. Maculopapular rash was from really the cream that we have, but the other ones were very, very small, very, very minimal compared to 99% of the medicines that I prescribe on a daily basis. So we were pleased to see, as you would expect with the natural medication, that the side effect profile was very low. Last 2 slides. If you read this, this is what Peter and I are trying to change. And this is the paradigm from the American Pain Society and the American College of Physicians, 2 very large groups that oversee a lot of pain issues, about how pain is treated. And this is the low back pain indications, which is the primary and largest subgroup of the population that they're treating. Acetaminophen or anti-inflammatory medications is first line for most patients. And this is recommended due to the favorable side effect profile rather than the efficacy. After failure of the first-line agents, boom, skeletal muscle relaxers, benzodiazepines, which I have really not even touched on in terms of dependency and addiction, as well as opioids. So for your primary care physician, for your rheumatologist, for your family medicine physician, for various types of healthcare providers across the nation, this is the paradigm that they're looking at for back pain. If you fail anti-inflammatories, I'll put you on Percocet. That's what the American College of Physicians says. So they have backup there. So while we're fighting this opioid crisis, there are a lot of physicians that are still using opioids as a very quick trigger, so to speak, if the patient fails, ibuprofen.